Alrighty. Pushing through here.
Yep.
Next one here, COMAT Review Series. High yield stuff, I would say. Going through electrolytes. Namely, potassium, sodium, magnesium, calcium. We'll throw on phosphorus there at the end. A lot of high yield stuff. A lot of high yield stuff, even for emergency department medicine, but especially for test taking purposes as well. These are the ones to know. These are the electrolytes most important that come up routinely, both on tests and in a clinical setting. Start with the most important, hyperkalemia. What's the most common cause? What's the number one cause of hyperkalemia? It's iatrogenic hemolysis. I've seen that question multiple times there. If it's hyperkalemia without any sort of EKG changes, repeat it and see what's going on.
And I think that's the key, is it's not true hyperkalemia. This is pseudo-hyperkalemia, where your lab result is elevated. And the question they're going to ask is, what's the next best step in an otherwise asymptomatic patient?
Perfect.
It's going to be redraw the potassium.
Yeah.
So that's the one thing, when you get the hemolyzed sample to always think about.
Perfect.
Because, we really want to treat... We want to treat other physical findings,
definitely,
which we'll go into here. So
yeah,
they'll give you the clue in the test question if it's not, or if they're asking you, if one of the answers is redraw, then you need to go really look. Is there a reason to do more?
Yeah. And what determines the severity of the potassium there? It will be the EKG. EKG goes in phases here, and you might get an EKG at different levels of potassium, and so it's good to know kind of how it progresses there. So think of the T wave as being filled with potassium. It goes up as the potassium goes up, and that's where that hyperacute T wave comes to play. As things go even higher, you start losing that P wave, things start widening out, and then the most severe is you get that widened QRS that then progresses into a sine wave, which you're in trouble, and treatment needs to start very quickly. Have you seen a sine wave?
Uh-huh.
Yeah, me too.
Mm-hmm. It's real scary.
It's pretty intense. Yeah.
Real scary.
Yeah. I've seen it on test question and in clinical.
I've seen it clinically. Yeah. It's not comforting.
Okay, treatment. And this one comes up all the time. You'll get a hyperkalemia. They'll show you an EKG. It'll have like the wide QRS, have the hyperacute T wave, and they're going to ask, which of the following will stabilize the cardiac membrane? And I feel like that's always that's a super common question here. And looking for calcium chloride or calcium gluconate.
And I think they could fairly ask, what's the first treatment?
Yeah.
What's the next best step?
Nice.
Anything that points toward hyperkalemia, really, this is always going to be the first step. You always want to give calcium. There's been a lot of research on this, and I think enough so that it's worth having test questions on.
Yeah.
That you want to give calcium however they offer it, so gluconate or chloride.
Perfect.
How you give that's clinical, but for the test purposes, giving that first is really the appropriate next step.
That's perfect. These next things down here are probably more clinical, but I agree. For next step in management of hyperkalemia is give calcium. Indicated if it's a wide QRS complex, if you see a sine wave, if there's bradycardia heart block. Usually, this is what's progressing when the potassium is getting elevated. But for test taking purposes, calcium stabilizes that cardiac membrane. First one that we give.
Yeah, so that's going to prevent your dysrhythmias, which is what you're really trying to do.
Absolutely. The next step is you're going to push potassium into the cell, and these ones are good to know because we treat hyperkalemia by either pushing potassium into the cell and get it out of there, or we push it out of the body. And there has been questions where, which one, will correct the potassium intracellularly, which one, excretes potassium, whatever it might be. Intracellular shifts, you're looking for glucose and insulin, a beta agonist, which is albuterol, which is usually a pretty high dose, but just knowing beta agonist is what you're looking for. Bicarbonate, plus or minus. I haven't really seen this on a test, sort of say. Really, it's been like glucose and insulin or a beta agonist for intracellular shifts.
And I think if you get anything like this, it'll be which of the following does not improve the situation, however they write it. And they'll have these 4 plus something else.
Perfect.
So I think the 3 on the right, be familiar with. The calcium, no, is your first line treatment.
Perfect. Then if they ask which one removes potassium from the body, we're looking for if they're making urine, we're going to give Lasix. And then there is ion exchange resins. Again, these are plus or minus, clinically, do they work, do they not? But for test-taking purposes, Kexlate or Lokelma.
And
poop it out there. And then lastly is obviously dialysis. Yeah. Next one moving right along is hypokalemia. So common causes here, chronic alcohol use, diuretics, vomiting, diarrhea, hyperventilation is what we're looking for here. The EKG does change with potassium as well. I have seen questions here. So you'll have the loss of the T wave that will go, and then a U wave will present up here, and that's this one right here. So following the T wave, you'll get a second kind of rise here, and that's that U wave that comes with hypokalemia. You also get a prolongation of the QT interval, and the reason why this is dangerous, obviously, because that then leads to torsades, which is not good. Hypokalemia, what makes that an emergency is that QT interval. So as that widens out to more than 500 milliseconds, that's what then puts you at risk for torsades. Hypokalemia, think hypomagnesemia, it all goes together. So we're treating hypokalemia, you're giving potassium, but you're also giving magnesium, which oddly enough is also the treatment for torsades. So it all comes together very well. Treatment, sometimes this has come up, think 10 milliequivalents, so a smaller dose. If it's a peripheral IV, you can give more in a central line. And then PO, potassium if you're going home, and then again giving magnesium. Some test questions I've seen that with hypokalemia, you give potassium and magnesium. That's more of a clinical point, though, I would say. Mm-hmm. Hyponatremia, we have covered this in the seizure lecture, which we'll reiterate again here. So most common cause is those diuretics, and we're giving sodium. If it's an acute, so you treat acute hyponatremia acutely, so very quickly. If it's chronic hyponatremia, it needs to be done over time. There's a lot of different things that I found as far as, how much should you recorrect the sodium, that plays it safe, 8 to 10, 9 milliequivalents, per liter per day, whatever it is. If it happened over a long period of time, it's slow correction. Mm-hmm. And really the question will probably lead you down to osmolar demyelination, will probably where that question ends up. Where if we correct the sodium too rapidly,
what's the consequence?
What's the consequence, or what have we acted on? What have we just caused? Yeah, and that's where osmolar demyelination will come into play. That's demyelinating disease of the pons, CNS. You get that flaccid paralysis, dysarthria, hypotension. Not good.
Yeah. So I think if you do see something like this, what you're thinking about is somebody who came in with hyponatremia. They were given hyperosmolar saline or hypertonic saline.
Hypertonic saline, yep.
And they began to develop dysarthria and paralysis. What's the next step? And it's going to be stop the hypertonic saline infusion.
Nice.
Is kind of what you need to be thinking about there.
Perfect. So where is it safe to give that hypertonic? So if they're seizing, again, going back to that seizing patient, you're giving that hypertonic saline, you have to correct that neurologic dysfunction. If they're acutely altered, there's focal findings. That's where you're aiming for. And typically that sodium level is going to be less than 120. I think we covered that again in seizures and here to drive home that point. And it's 3% hypertonic saline is what you're giving.
And you're treating the symptoms here, and I think that's the other big key is that the number tends to be less than 120, but you're treating that seizure, that hyponatremic seizure. You're treating the altered mental status. So you're not just using this as a resuscitation fluid.
Right.
You're using this as a medication.
Nice.
So you think of your hypertonic saline as a medication, and then once we've got that corrected, then we can move on to just filling up their tank using regular fluids.
Perfect. Hypernatremia, most commonly caused, will be like a dehydration. Obviously, we'll repeat that with giving fluids. LRs, normal saline, whatever you'd like. If this was someone who drank a bunch of
salt water
or something to that effect, that's where the D5W, the diuretic, comes into play. And then the problem here is that if you correct too quickly, so I always think if you're high to low, the brain will blow, cerebral edema, and if it's low to high, the pons will die, and that's how I remember the two different ones there. So again, corrected too quickly, you get that big old brain, cerebral edema, and again, not a good outcome for the patient. Hypocalcemia, and this question is either going to be the Schoenstein or the carpal pedal spasms. Is where I think calcium comes in largely here. So cheek, Schoenstein, the carpal pedal spasm, you see this one come in where you put the blood pressure cuff on the patient and their hand, spasms up, and classically associated with calcium. What's the treatment? You obviously give calcium.
Yep.
On the opposite side of the spectrum there, if it's hypercalcemia, commonly it's going to be like a cancer patient. You have like the groan, stones, the psychiatric overtones will be the presentation. Big treatment on this one is you give saline, so then they can urinate out the saline and then the calcium. And if you're giving too much or they're becoming fluid overload, then you can give the Lasix as well. Usually this becomes an issue if it's greater than 14, if we want to throw a number to that as well. Hypermagnesemia. Well, that one's a hard one to say quickly. So this is a great one, too, to link it back up into the seizure lecture as well. You know, you got the 20-year-old female, postpartum, seizing, doesn't respond to the Ativan, doesn't respond to second line.
Right.
You find out that she's postpartum 2 weeks. You think eclampsia. You give magnesium sulfate. Maybe you give too much. And then, you know, you check the deep 10 reflexes, and now they're going down, or you're getting low reflexes. You know, what have you caused? And that's the hypermagnesemia state. Give calcium.
Right. And that's the way I've seen this before too is so the order this happens is we check DTRs because that tends to be the first sign that we can elicit. That the next kind of step in the progression of that is respiratory depression. So that's the other thing is they may ask you, you know, what do you need to prepare for? And it's, you know, prepare to manage the airway is what we're looking for.
Perfect.
And you may get caught between a rock and a hard place where you're trying to treat eclampsia, you're trying to treat a seizure, and that's the logical next step is that you have to treat the seizure. You cannot let them go on into status epilepticus, and so you have to prepare for respiratory depression. Which is caused by hypermagnesemia. So
perfect.
I think the important thing to keep in mind is with the hypermagnesemia, it starts with a decreased DTRs and progresses to respiratory depression and bradycardia.
Perfect.
So.
Perfect. And I'll throw this one in as well. So hypophosphatemia, if this is a, you know, chronic malnourished patient, hyperventilation, this can become severe, so you can get decreased contractility of the heart, you can get decreased ventilation, you can have rhabdomyolysis. Treatment, you know, based off of the numbers there. So if it's less than 1.5, consider therapy. Less than 1, you should be seeing those symptoms, and then you treat half cc's per hour of K-phos. That's all. High yield stuff. Ooh. We have questions. I don't have questions on this one. Perfect. All right, let's practice. 30-year-old patient is found to have a metabolic acidosis with a pH of 6.9. Which electrolyte abnormality is associated with this pH? Interesting. We really
so remember what happens when you've got all the hydrogen ions in the vasculature or in the extracellular space.
Perfect.
It's gonna try to push those into cell. It has to exchange it for something. So what's it going to exchange it for?
Perfect.
It's going to exchange it for potassium.
Potassium. Perfect. Question number 2. I already gave you the answer. EKG associated with this electrolyte abnormality. So again, we're looking for torsades here. Hypokalemia, hypomag, that prolonged QT interval that then progresses into that torsades presentation. Not a very good question when I give the answer as the first one there. All righty. Osmolar demyelination occurs with what electrolyte shift? So are we overcorrecting which one? Sodium from a high to low, low to high, or a calcium? And again, I always think of this one here, osmolar demyelination, low to high, the pawns will die. That's osmolar demyelination. Syndrome that we want to avoid when correcting for sodium. That's all. Thanks, guys.